Αγαπητοί συνάδελφοι, κυρίες και κύριοι, καλή σας μέρα. Θα ήθελα να σας καλωσορίσω σε αυτό το συμπόσιο και θα μου επιτρέψετε να συνεχίσω στα αγγλικά, χάρη των διακεκριμένων ομιλητών μας, που και αυτοί θα μιλήσουν στα αγγλικά. So, I want to thank Novartis and the organizers for the privilege to moderate this symposium on the advances we are expecting in pharmaceutical therapies of our retinal patients in the near future. I'm honored to introduce you to esteemed colleagues today with extensive experience in retinal pharmacotherapy and continuous presence in international retinal forums. Most probably you have already know them both. Dr. Anat Lowenstein, Professor of Ophthalmology and Associate Dean of the University of Tel Aviv Medical School. Professor Lowenstein will present us upcoming pharmacological treatment options for wet AMD patients. And Dr. Matus Rehak, Professor of Ophthalmology in the University of Leipzig and Managing Director of the University Hospital there. Professor Rehak will discuss the role of fluid in wet AMD patients and present a very, very interesting series of real-world cases. So after several years of relatively slow progress in retinal pharmacotherapy, we are now in front of a considerable step. And Professors Lowenstein and Rehak will give us an interesting insight into this upcoming progress. We will start with Professor Lowenstein. Anat, please.
Hello, everyone. Good morning. It's a big, big pleasure to be part of this symposium and this meeting. And I would like to thank very much my colleague, Professor Tsilimbaris, for the honor to be invited to this symposium. We know each other very, very well. We participated in many meetings together. And now it's sad not to be in your country live. But I hope this will happen again in the near future. And it's an honor for me also to do this symposium together with Professor Rehak, with whom I also work very closely on many things. I look forward to the whole symposium. So I will share my screen. Sorry. Can everyone see my screen?
Yes, yes,
okay.
Anat.
Okay. So, as Professor Tsilimbaris alluded in his introduction, we are very fortunate in the recent few years that finally, after what we had excellent treatment that included many anti-VEGF agents for, I think, the last 15 years, we finally face some new developments in this exciting field of neovascular macular degeneration management of patients. I'm acknowledging my financial disclosure, and this is a non-promotional scientific purpose meeting. So let me start by presenting to you the 77-year-old patient of mine who comes with decrease in vision in the right eye for the last months. Visual acuity is indeed decreased to 615. And clinical examination as well as OCT established the diagnosis of CNV secondary to macular degeneration. The patient is seen, this is how she's seen 2 weeks after presentation. She's treated by 3 injections of an anti-VEGF agent. And as you can see, according to the OCT, judging the OCT and also the lack of improvement in visual acuity, but mainly the OCT, there is no improvement whatsoever. The patient is switched to ranibizumab, to one of the registered drugs. And this is how she is after a month, a very good response. Then she doesn't come because there is, she had pneumonia. You know, when a patient is sick, he doesn't go to the ophthalmologist. And he, of course, according to the OCT, we use the OCT to decide that, yes, she needs therapy right here. More injections, she responds very nicely. And maybe according to the OCT, we can decide that if she's treated by PRN, to withhold 1 month or depending on the method of treatment. So when I described to you this patient, I showed you that we decided according to the OCT on how to treat the patient next. And if you look at many analyses that were done, and here on this slide, you can see an analysis that was done by Professor Usha Chakravarty in Belfast in the UK, that looked at the reason try to understand the reason why patients are retreated or non-retreated. And the way they looked at it was to look at the charts and see what was the situation in injection visits as opposed to non-injection visits. And you can see that when you look at visual acuity, there isn't a big difference between the two situations. In contrast, when you look at intraretinal fluid, subretinal fluid, and increase in central subfold thickness, and macular hemorrhage, in all of these, there were much more visits that prompted an injection. This means that as a whole, I'm not saying that this is 100% of the time, but as a whole, we are more using the OCT as compared to visual acuity, as opposed to visual acuity when we decide on treatment of patients, on retreatment of patients. Of course, the need, to see the patients very often, to do an OCT, to interpret the OCT, and then to treat the patient causes an unbearable burden on the patient, the physician, and on the system. And what happens is, all of you know, in clinical practice, fewer injections are administered than in the clinical trial. This results in a situation where at first the visual acuity improves significantly, but later on there is even not stabilization, the visual acuity decreases. If you look at the 7UP trial, after a few years, there is a decrease in visual acuity only because the patients were not treated. So what is the challenge that we have in the management of AMD patients? We want to maintain the efficacy of the therapy while reducing clinic visits and improving the compliance, lowering the burden on all parties involved. How do we do that? So one exciting approach to do it is by use of, fortunately, drugs that we now have nowadays that are longer lasting. We also have a new slow release device. I would like to present to you my field of research, which is the home OCT, which includes an automated analysis of the OCT findings. And the first drug that I'm going to talk about is brolucizumab. Brolucizumab is a very interesting drug. It is engineered by advanced biotechnological methods that overcame the challenges of developing a single chain antibody fragment, which is actually the brolucizumab drug. Brolucizumab is the first single chain antibody fragment that is approved for use in ophthalmology. And as such, because it is a single chain antibody fragment, it is very small. Its molecular weight is only 26 kilodaltons. Since the clinical dose is 6 milligrams, then the relative number of molecules per injection is so many times higher than the other drugs that we know from clinical practice from before. This has the potential of a significantly increased efficacy. So just to say a few more words about the molecular characteristics of this very special drug is that, as I said, you can, in a single injection of 6 milligrams, you have many, many molecules. In addition, it is a very potent inhibitor of VEGF-A. Because of its size, it penetrates significantly the retina and the choroid. And another advantage is that it's cleared from the systemic circulation relatively fast. And we all know the results of the Hawk and Harrier trial that showed, first of all, from the point of view of visual acuity, at the primary endpoint that was at 48 weeks, brolucizumab had similar visual acuity improvement as compared to the comparator, which was aflibercept that was in the Hawk and in the Harrier. And this same visual acuity results was maintained over the 96 weeks, which is the end of the trial. So we have very good visual acuity results. There is a small issue with the design of the trial, that the trial did not allow aflibercept to be given in a longer time interval than 2 months. And that was because always a trial needs to compare to the standard of care, to the label. So aflibercept was not given the chance to have a longer duration. However, there are a few points in the trial where there is a very fair comparison. One obvious point is week 16. At week 16, everyone in the trial was 2 months after the last injection. Everyone, agnostic of the treatment. And you can see that in the eyes treated by aflibercept, there was much more, 35% more disease activity as compared to the 2 arms treated by brolucizumab. Another very important point is the effect of brolucizumab on retinal thickness. And here you can see in a very clear manner that brolucizumab, plotted in the blue line here, dries the retina more. You can see that in the aflibercept arm, there is a less drying of the retina and also a much higher seesaw pattern. Every month that there isn't an injection, there is an increase in retinal thickness. And I will get back to it in the next slides. So we see that the drying of the retina, the existence of fluid, the influence on the existence of fluid is better with brolucizumab as compared to aflibercept. And this is an important criterion because when you look at all the clinical trials, all the pivotal clinical trials, the retreatment criteria were always based on OCT. Some of them had also visual acuity criteria, but the most important one, the most common one is OCT. Moreover, when you look at society guidelines, be it the EURETINA guideline, the Royal College of Ophthalmologists in the United Kingdom guidelines, and the AAO guidelines, all of them determine that OCT is the key characteristic upon which we decide our treatment and retreatment decisions. Oh, sorry. Okay. I want to give you an example of a patient that had in the trial that had subretinal fluid. You can see at week 12 the amount of subretinal fluid here, and then the subretinal fluid decreases. Just as an example to show you that this can also influence the visual acuity. Another analysis of the Hock and Harrier, which is maybe new for some of the listeners, looked at pooled treatment and study data for the central subfield thickness variability analysis. And this divided the levels of fluid to quartiles. Quartile 1 had the smallest central subfold thickness variability, and quartile 4 had the highest one. And that was analyzed agnostic to the treatment. A similar analysis, by the way, was done for the CAT and IVAN trial prior. So now you see both analyses. So both for CAT and IVAN and for Hock and Harrier, when you go from low variability to high variability, the levels of visual acuity are better the lower the variability is. So it is very important to keep a constantly dry retina for the final visual acuity results. Another sub-analysis separated intra and subretinal fluid and PED volumes and showed that when you look at both at Hock and Harrier, there is a better visual acuity in cases where you have a lower variability, a lower subretinal fluid existence, a lower intraretinal fluid existence, and a lower PED. Another post-hoc analysis showed greater best-corrected visual acuity gains observed in eyes with controlled subfoveal thickness. And you can see it when the controlled thickness was lower than 280, lower than 320, and lower than 360. And that was treatment agnostic. So just to summarize the fluid issue, retinal fluid is considered a disease state, and according to all the guidelines and the pivotal trials is a reason for treatment and retreatment decisions and brings along a better visual acuity outcome if it is more stable. I already emphasized this fact that at week 16, patients in the aflibercept arm had higher disease activity as compared to the 2 brolucizumab arm, and that was true in the Hock and in the Harrier trial. Another important point is, of course, the duration. And we can see here that over 50% of the 6 milligram brolucizumab arm were maintained of a Q12 dosing interval until week 48. That was 56% as you can see in this slide. Moreover, if a patient could complete the 12-week interval, namely after 12 weeks, they did not need to go to lower the interval to 8 weeks, then he had 80% chances to continue this way until week 48. Moreover, of the patients that were able to complete week 48, that 80% from before, over 70% could continue this way until week 96. And this is a very important point. So if a patient started as a good responder and a lower duration acting eye, you can count on about 3/4 of the time you will continue that way for at least 2 years. Overall, brolucizumab had a good safety profile. And this you can see by many ways. But one way to look at it is that you compared the chances to lose vision. The patients with more than 3 lines lost from baseline at week 96, the number is very similar across the 3 arms, both in HAWK and in HARRIER. When you go into more detail of intraocular inflammation, then yes, we all know that there were issues with inflammation in the brolucizumab arms. When you look at the percentages, they are written here in this part of this table, and after rounding by the FDA, the rates, and I think this is the numbers that we need to remember, it was about 4% to have some kind of intraocular inflammation, 1% to have artery occlusion, and 1% to have endophthalmitis. And this was, of course, a worrisome data. And then there was a post-marketing update saying upfront that there is a safety signal of rare adverse event of intraocular inflammation. Novartis is looking very carefully into it by think tanks, by group, by discussion group, by establishing a safety monitoring committee. You can get all the information on brolucizumab.info, and I think it's very interesting to see. And we still need to learn a lot about this. Altogether, this is an analysis of all the patients that had intraocular inflammation. So altogether, it was 4.6%, retinal vasculitis in 3.3, and retinal vascular occlusion in 2.1. There are some recommendations about this issue already. So first of all, we need to educate the patients to report if they have floaters or other symptoms. We are not treating patients that already have inflammation by brolucizumab. There is a request to do some wide field imaging if possible, and if there is inflammation, to treat it freely and relatively aggressively with steroids. So just to summarize from the HAWK and HARRIER clinical trials, we have good visual acuity results with superior anatomic outcomes, less disease activity, more than 50% able to be maintained on 12-week interval with a prediction to for the first and second year, and with an overall good safety profile with the acknowledgement of existence of intraocular inflammation that needs to be looked at, monitored, and treated. I'll say a few more words about some other treatment options that we have nowadays. Another drug that is going to be interesting in the future is faricimab. Faricimab is a bispecific antibody that was engineered for efficacy and duration within the eye. It has it's one molecule that has 2 targets. One is the regular anti-VEGF-A FAB that we all know. The second is anti-Ang2, and we think that Ang2 is important in intraocular vascular stability, and an optimized Fc receptor. We do not have yet results for the phase 3 trial for AMD. We do have for DME. But the phase 2 trial, there were 2 studies. One is the stairway, and you can see that the faricimab-treated eyes which were used at Q12 or at Q16 with the possibility to reduce to Q12, they had visual acuity results that were comparable to those of ranibizumab. So very promising results. And this is the second AMD trial on faricimab, the Avenue trial. And you can see again that the faricimab treated eyes, even though they could get faricimab in a longer duration interval, they achieved a meaningful vision gains and a central subfield reduction for patients with macular degeneration. We are waiting for the results of the TENAYA and Lucerne for neovascular macular degeneration management. Another potential option that we will have probably, I hope soon, is the port delivery system with ranibizumab, which provides continuous intravitreal delivery of a customized formulation of ranibizumab. It is a permanent, refillable intraocular implant that needs to go into the eye in a surgical procedure, but the refills are done in the office. And you can see the results here of the Archway trial, which was a phase 3 trial that showed that with a refill of every 6 months, the PDS was non-inferior to monthly ranibizumab. So very promising result. Of course, we also have an issue with side effects. It seems as though whenever we try to go longer, there is some issue with side effects. The most important one that I can show you here is the existence of vitreous hemorrhages, but this was reduced after a change in the protocol and the issue of conjunctival erosion. So, but we cannot say that there aren't any side effects. There are some other drugs coming up. I am not going to talk about them in detail, just to say a few words about RGX-314, which is an anti-VEGF treatment delivered by a novel gene therapy methodology. It is a donor-associated virus that is injected subretinally and inhibits VEGF for years potentially. We are expecting more results by the end of the year. Drugs that are actually used for non-neovascular AMD are also looked at for neovascular AMD, trying to also combat the complement system also for neovascular disease, but we still do not have published advanced phase results. I would like to finish with just mentioning the HOMO-CT. The HOMO-CT is a method to personalize the management of AMD. We think that to have a HOMO-CT monitoring can be helpful in catching and treating neovascular disease, the wet days, as soon as they happen, and therefore providing patients and physicians with inter-visit knowledge. This potentially, it's like a true PRN. The minute you get the fluid, you are called to the physician, you are getting a treatment. This can avoid under-treatment and reduce the treatment burden. So this is the device. This is how the images look. It monitors intra and subretinal fluid based on daily patient self-imaging. It's easy to use. The scan is only 30 seconds per eye. We showed a very high sensitivity and specificity compared to commercial OCTs. And what is really important is to have the AI algorithm that looks at the original B scans, does segmentation of the internal limiting membrane and the RPE, detects the intraretinal and subretinal fluid, and produces a map of intra and subretinal fluid. Then the diagnostic clinic reports the existence of the fluid to the physician and to the patient, and the patient is called to see the physician. This is how the commercial form will look. And this is just to show you the image quality, which is very nice. It's very similar to that of Spectralis. And this is an example of a patient that was followed longitudinally at home. And you can see how slowly the fluid increases. And it is very obvious on the scan. The patient is treated and the fluid decreases again. This is how the automated analysis is done. There is segmentation, detection of the fluid, a fluid status report, and a production of a map. And here you can see longitudinally what happens to the patients. So to sum up my talk, we have new things coming up to lower the burden by still keeping the good efficacy by new long-lasting drug, such as brolucizumab, slow-release devices, better and easy monitoring with automated analysis. Thank you for your attention, and I look forward to continuation of this symposium.
Thank you very much, Anat. Thank you very much for this very, very informative presentation. So we have excellent news, new drugs, and new ways to follow up our patients. this is very, very interesting. If one could make a notice from your talk, I would say that VEGF remains our main target, although it seems that we will have other possibilities in the future. For the time being, we still go after VEGF, and new drugs, long-lasting drugs, will help us. And brolucizumab is the first one, and it seems that it is very effective, with the asterisk of the inflammation, of course. And also, it seems that morphology will be our main guide in this work. And with this excellent work that you presented from your clinic, it may be some of our work will shift to the houses of our patients, which may be very, very helpful and interesting. So our next talk will be Professor Rehak. Professor Rehak is practicing in Germany, and he has the great advantage to have almost 1 year experience with a new drug, with brolucizumab. So he will present us some most weighted real-world data coming from his clinic about the drug. Professor Rehak, unmute, please.
Thank you so much. I hope you can see my screen.
Yes, indeed.
It should be larger. So, first of all, it's my great pleasure, Professor Miltiadis, and thank you for your invitation. It's my great honor to speak also with Anna Löwenstein with this symposium, and she did a perfect job and explains us how retinal fluid is important and how it's influencing the treatment strategy. And I would like to combine two targets. The first one with focus on this retinal fluid and different compartments of the fluid to discuss how we can treat and when we should treat. And I will share the experience with brolucizumab from our department. As you mentioned, we have already almost 1 year experience, and I'm really happy. Even it was a difficult year with COVID. So as we started, the Corona pandemic started, so it was really difficult to reorganize all these intravitreal treatments out of clinic. But I think we managed it quite well. And I would like to start, of course, with my disclosures. This is the presentation of my personal experience. So there's not coverage with the meaning of Novartis company. And I will like to show you the first case. Is a treatment-naive patient. We started with the treatment last year in March. It's a lady, 69 years old, coming because of the right eye, has a slow progressive decrease of the vision in last 2 months. And if I show you the OCTs and the fundus, then I think we can already start to discuss what shall we do? Do we need to treat? It's a very particular case. But just give you the background information, this lady was observed over 2 years in other eye departments, and they were not sure, as the vision decreased on the right eye, whether to start to treat or to observe. So she came for the second opinion to our department. We performed, of course, FA analysis, and you can see this is not a clear neovascular activity visible. Probably we should do also ICG, but this is not what we are doing routinely. And due to this pandemic situation, it was difficult because we are moved to the another building because of the outdoor clinic. So there's no possibility to do the ICG. So we have only FA images, but after long discussion with the patient, and we see this huge prominent PED, and this is a small intraretinal fluid. I'm not sure whether you can see my pointer, but you can see in the OCT image. I don't think there's a treatment relevant fluid, but because there was this vision decrease and the lady actually wished to do something, we decided, okay, we can try to treat. And because we had the data from Hoke and Herriot trial, and we know that brolucizumab is a perfect treatment option for subretinal fluid and PED, we decided for the treatment as a first line with brolucizumab. So this is the day of the first injections. We always perform OCT, visual acuity, and fundus and dilated pupils before every single injection. So therefore we have this nice data. And you can see already after first injections, there is a significant reduction of the PED. There is no improvement in the vision, what we also didn't expect it. But after second injections, there is almost no PED anymore. There's a slight increase in the vision. And then we went, as the label says, 8 weeks later for the fourth injections. This is almost completely flat retina. The vision is 0.6. So then we extended to 12 weeks. And the fifth injection was in October 2020. The vision was already 0.8, so the same as in the left eye. And we wanted to stay with the 12 weeks, but actually last week there should be the 6 injections, but the patient is now in the quarantine because some relatives in the family have a COVID, so she postponed the appointment for the February. So we will see, it will be more than 12 weeks. Maybe we will get the experience that also longer treatment intervals is still okay, so we will see. But I think that also this example, after 5 injections, there's absolutely no PED anymore. There's a completely dry retina and the vision improves significantly. This lady is very happy. So it gave us a little bit satisfaction that was a right decision, even we were not so sure and also not so happy. Probably I will personally a little bit wanted to wait, but she wanted to get treated. So the second case is a patient with pre-treated eye. You can see there's a 78 years old lady with a slow progressive decrease of the vision in the last 3 months on the left eye. This right eye has only mild cataract and dry AMD changes vision, and the right eye is 0.8, the left eye is 0.4. There is also PED, not so high, more flattened, and there is also subretinal fluid. We are in August 2018. So these are the angiographic images. You can see there is a leakage in the left eye, so there's a neovascular activity, and we decided to go for anti-VEGF treatment, and we started with aflibercept. So these are the first 3 injections. You can see there's still subretinal fluid, there's still PED, there's no improvement in the vision, so we are not so happy, not so satisfied. Therefore, we decided to check again the OCT 4 weeks after the third injections, and also to decide it, because there was no further improvement, to inject again already 4 weeks later, so not at 8 weeks as it should be actually expected. And 4 weeks later, there's further decrease of the vision, so we concluded as a non-responder to aflibercept and switched this patient to ranibizumab and started with ranibizumab. You can see there's a slight improvement also in vision, also in the subretinal fluid, but the retina is not completely dry. So we already in 2019 followed the treat and extend strategy. So we tried to extend a little bit, but it didn't work that much. So we stayed by 6 weeks and went for 5th ranibizumab. And in July 2019, it's the 6th one. The vision is 0.5, so there's only very mild improvement and still persisting subretinal fluid. So after 1 year of treatment, we have already 6 ranibizumab and 4 aflibercept injections, very high numbers of treatment we got. And in September, there was, in November, there was a further decrease of the vision and increase of the subretinal fluid. So we went back to aflibercept, probably because of suspected tachyphylaxis or something like that. So we switched back to aflibercept and did a new upload with 3 monthly injections. You can see in December 2019, 0.4, no improvement. Also 4 weeks later, in January this year, absolutely no improvement. So therefore, in February, we decided, as we knew the new drug will come in, so the brolucizumab will be available in next week. So we will switch this patient to brolucizumab. And we got the first injection in 12th of March. And you can see this is 1 month after the first brolucizumab. there is still persisting subretinal fluid. We were a little bit disappointed. Probably we expected a little more miracle, that there will be absolutely nothing anymore. It was not the case. So we did the second injections, but you can see there is a slow improvement. So you need to be a little bit patient. 4 weeks later, the PED is not so prominent and there is much less subretinal fluid. So 8 weeks later, on the day of the fourth injections, there is no subretinal fluid anymore. We are in July 2020, and there's an improvement of the vision. This is 0.6, so we have never so good vision before. And 8 weeks later, there is still stable vision, no subretinal fluid. The fifth injections, and then we decided to go for 12 weeks. And you can see in January this year, so this 2 weeks later, there's still dry macula after 12 weeks, and there is very nice, very good results. And the patient is very happy because she had a long treatment interval, 3 months. That's really important for this patient, and their vision is still stable. So as a conclusion from these 2 cases, I think that we could see that brolucizumab is in naive patient and also with in cases with persisting disease activity, very good treatment options, which is leading to faster reduction of PED and subretinal fluid. It gave us a chance to prolong the treatment intervals, and the patients are very satisfied. Anat mentioned one important point, and this is the safety issues. It means the intraocular inflammation, IOs. And this is what we also observed. We could see, or we saw few patients from our department, and we saw some patients also which were sent to us from other centers which were treated. And I would like to share our experience with 2 cases of these safety issues. This is a lady, 64 years old, with late AMD and history of 14 aflibercept and 4 ranibizumab injections. And we decided to switch the treatment to brolucizumab in April this year, last year. So these are the last images we have from January 2020. There was a visual acuity in the left eye, 0.3. This lady was under 7 weeks interval of aflibercept, and there was persisting subretinal fluid. And you can also see these fibrotic changes in the central part and a small PED. So this was the day of the first brolucizumab injections in April. Vision was 0.4. After first injection, there was a significant improvement of the subretinal fluid. And then she came in June 20 for the third injections. There was dry OCT. She was fine, she was happy, but we were not happy because there was a decrease of the vision from 0.4 to 0.25. So all the nurses get an alert call where there's something wrong. So we did also the fundus images, and you can see this typical infarction of the nerve fibril layers, so cotton wool spots, and there are also some perivascular changes in the papilla area. I can share the FA images. I have it a little bit larger. And we concluded as a retinal vasculitis without ischemic changes. So there is no impairment in the perfusion, but you can see this very small segmental changes in these retinal arteries, very small details, but it leads to the decision to discontinue the brolucizumab treatment. So we immediately did not any further intravitreal injections. We gave to this lady systemic steroids intravenously for 3 days, 100 milligram. And we observed it very carefully and very frequently. You can see this was in June 2020 at the day of the planned brolucizumab injections, then 2 weeks later, and 12 weeks after the last brolucizumab, and there was a spontaneous increase of the vision back to the previously vision of 0.3 to 0.4, and there was no activity for 12 weeks. After the 12 weeks, she got a new subretinal fluid, and we decided to treat it with ranibizumab as PRN. So now she's under ranibizumab treatment, of course not with so long intervals, again with 6 to 7 weeks, so more frequently, but we are afraid and we are not going anymore for brolucizumab treatment. But I think if you recognize this issue in the very beginning of the stage and not continuously treat it further with brolucizumab, you can prevent probably very bad and severe impairment, which might be also permanent. Another case is old gentleman with vitritis after 3 brolucizumab injections. He had also a history of 15 aflibercept injections. Prior to brolucizumab, the vision was 0.3. You can see on the day of the 3rd injections, there's a very bad image quality of the OCT, but I thought probably, I mean, the young nurse was taught and trained, so the image quality is not so good. There was nothing. He was happy. We couldn't see anything more, so we did the 3rd injections, and 4 weeks later, he's coming and reporting about floaters, which are flooding in front of this treated eye, and you can already see in this SLO images, so not on the B scan, but when on this red-free images from the OCT, there is some shadowing. And this is what is a clearly sign for the vitritis. So we discontinued the brolucizumab treatment, and now we need to be also very self-critical and look to the OCT image before we did the 3rd injections. There was this very slight shadowing already visible to that time that probably we did not recognize it early enough. We could probably prevent this adverse events if we could if we would discontinue the treatment already after the 2nd injections. So the image, how it looks like, he was with cataract, so the image quality is bad, but you can see in the detail this shadowing down to the macula and optic nerve, and this is what really moved like some shadow in the vitreous cavity. So again, discontinuing of the brolucizumab treatment. We did not treat him with the systemic steroids because he had a history of tuberculosis, and the ELISpot was once positive, then again negative. So there was a discussion if we give him the systemic steroids, probably with anti-tuberculotics. So we decided not to treat it with steroids, only observed. And you can see also the spontaneous improvement in further weeks. So 6 weeks after the last injections, 0.2 is the vision, then slightly improvement, and 12 weeks after the last injections, the macula is still dry. He stayed stable for 14 weeks after this 3rd brolucizumab injections, and then we switched him again to ranibizumab as a PRN. Now is about, I think, every 7 or every 8 weeks under the treatment, but there was a spontaneous improvement of this vitritis without any systemic steroids or any other further treatment, so only because we watched and observed it. So this is what we are doing now in Leipzig, like an internal checklist in all single patients with, who is treated with brolucizumab. ABC rules, it means ask the patients if they saw something what is new, like a floaters, shadows, or something what is impairing the visual acuity. Then be careful with the OCT interpretation. Do not look only onto the B scans, but also look to the SLO images on the left part of the OCT image, and look for the shadowings, because this is much more better to see this very slight inflammations signs in a vitreous cavity. Sometimes it's really difficult to see it by the fundus investigation, but of course the C is check the fundus, check the AC for haze, for cells, for any changes, and also on the changes on the retinal vessels, because as I showed you, the first case with vasculitis, this lady did not recognize anything. She was very happy, but there was already something that could be very dangerous if we would give the next treatment. So the last case I brought to you is again a pre-treated patients which we switched to brolucizumab after long history of the treatment. This lady came in January 2016. It was the only one eye. And you can see the right eye is already scarred. The left eye had this subretinal hemorrhage. So there's a macular bleeding with active CNV. The OCT and fluorescent angiography pictures are demonstrating. We did the recombinant RT-PCR and gas injections, and then started with aflibercept treatment in January 16. And you can see good improvement after 3 injections of aflibercept. 8 weeks later, the macula is dry, the vision improves perfectly to 0.5. The lady was satisfied. Then the treatment went further up to the 15 months after 9 injections of aflibercept. The 10th one in February 17, and then the subretinal fluid came back. So the improvement or the effect of the treatment is decreased. After 11 injections and 8 weeks interval, we have more subretinal fluid. There's some scarring, there's decrease in the visual acuity. So we switched the patients because of the suspicions tachyphylaxis to ranibizumab. But to be honest, there was no improvement with the ranibizumab, so we went back to aflibercept in November 17. And you can see we shortened the intervals. 4 weeks, 8 weeks is too long, so we need to come back about 5 weeks. And then we kept these intervals between 5 to 6 weeks over longer time, up to, and you can see as the patient once could come because of the pneumonia, there was a significant and a huge increase of the subretinal fluid in February 19. So we kept it about 5 to 6 weeks up to the November 19. And then also this short interval with 5 weeks was too long. There was still persisting and really huge amount of the subretinal fluid and significant decrease of the visual acuity. So we went back to 4 weeks. And even with 4 weeks, we are not able to get this macula dry. And this is the single or the last eye. So therefore, we decided in February 20 to switch to brolucizumab. Again, we have a PED, we have subretinal fluid. So I think this could be the good candidate for this new drug. And you can see how it works. The first brolucizumab, the second, again, no much differences. Be patient, follow the treatment. After the second injections, there is an improvement. And after the 4 injections, we are now in with 8 weeks interval, 0.3. The macula is dry in August, or almost dry. We kept the 8 weeks because it's the last eye and there's very small amount of the subretinal fluid still presented, and went with the 8 weeks further. And then this was not me, the colleague was, I think, very enthusiastic and decided to go for 12 weeks. So the lady came 2 weeks before ago, and you can see there's an increase of the subretinal fluid. So 12 weeks is too long for this patient. We need to go a little bit back to 10 weeks and we will see. But of course, if somebody was treated over 4 years and at the end of this treatment period every 4 weeks, and this is her last eye, then is this improvement and also the treatment interval of 10 weeks a huge improvement. So she's also very, very happy and satisfied. So I would like to conclude with these 3 cases what I showed you, that brolucizumab is a very effective treatment with good reduction of the subretinal fluid and also PD, and in some cases also with intraretinal fluid. It gave us a good results in cases also with poor response to another different anti-VEGF drugs, and give us the chance to extend the treatment intervals, reduce the treatment numbers of the injections and appointments, and therefore these patients are very happy if they get this chance not to need to come to ophthalmologists so frequently. So thank you for your attention, and I'm expecting your questions. I'm happy to answer your questions.
Thank you very much, Professor Rehak. Very interesting data and very interesting information indeed. I think we will have some discussion. We have already some questions, so I hope we will be able to address them. We will start with a question coming from Dr. Haronis. Alexandros is asking, among eyes with disease activity at 16 weeks, eyes treated with Brolu showed superior drying compared to aflibercept. However, there is a clear-cut sawtooth phenomenon. Do you think that brolucizumab's advantage is mostly driven by efficacy, but not durability? Will this affect the maximum extension of our treatment intervals in our practice? Professor Blumenstein, please.
Thank you very much, Professor Tsilimbaris and friend who asked the question. I think it's a very good question. So what you acknowledge is, yes, indeed, there is less disease activity on week 16, which is 2 months after the previous injection for everyone in any group. But when we look at the whole sequence of retina subfield thickness, there is some CISO appearance. If you look at the CISO appearance, it is much less in the brolucizumab arm as compared to the aflibercept arm. Actually, I think that in both arms, it's not that big, but there is some CISO appearance in both arms, for both drugs, but it's more pronounced for aflibercept. And I think that there is also proof for longer duration. You know, it is true that the durability was not directly compared between the two drugs because aflibercept needed to be given according to the label. But the fact that we have 57% of the patients that could go 12 weeks and in the first time, and from them, 80% in the first year and 75% for the second year could go 12 weeks, alludes that there may be a longer durability. I think you are right that there is no direct proof for that, but I think that still we have enough clues to show us that there is enough durability. But your question is excellent, and I think one way to actually follow it up is by ways of the home OCT to see when actually the fluid returns in a large bulk of the patients.
Thank you very much, Anat. Thank you. So there is a second question, this time for Professor Ehak. It's coming from Dr. Moutos. How much more time we really need to recognize and confess that brolucizumab should be promptly discarded as a failure due to unacceptable high and serious, due to side effects? Moutos, can you please comment?
Yeah, that's of course a very relevant question. You know, it's difficult from our personal experience because we have maybe less than 50 cases now, also patients treated with brolucizumab. But I think what we learned, the most of these all adverse events we saw at the beginning of the treatment. I think that was also driven that a lot of colleagues, not in our department, but in other centers, were very happy to have a new chance, and they started to treat everybody with it and did not look so carefully maybe prior every single injection. So I would say there is a chance for some side effects. How serious they are, I think we can influence it also ourselves if we looked carefully and discontinued the treatment in the early stages. If there are first signs of some changes in vitreous on the retinal arteries, then I think that we can prevent these very bad cases with significant visual impairment or vision loss as were described in the literature. But if you just put 3 injections without checking it in between, that you might run the risk for these bad cases.
So your suggestion would be that we need to be careful and detect any sign of inflammation early enough so that
this is actually what also Novartis did. Also the campaign in Germany, they did flyers also for the patients that they should be. So everybody who is under treatment with brolucizumab had a separate consent, is informed about these possible side effects. It's, you know, you need to be careful not to get the patient scared that they will get something what is really dangerous, because it's not the case. But you should open or oftenly discuss with him or with her. And I really appreciate that Novartis is also very open with this topic. As Anat showed, there's a homepage. You can follow the actual data from the real life. So this is nothing what they want to hidden, that there is no issues. There are some issues. Nobody of us, unfortunately, know who is in the risk or what is the mechanism. So there are some theories and there's a lot of research behind this. But now we should discuss it with the patients, be careful. We also should invest the time before and look for it actively. Yeah.
Yeah, I would like also to comment about that. I think this is also a very important comment. I have to tell you that before these intraocular inflammation cases came up, I thought that for me personally, the minute the drug will come on board, I will use it for every patient because I want to give them the chance of 60%, 57% to have longer duration. After these reports came out, I'm not going to use it on any patient. I'm just going to use it on patients that don't have inflammatory disease in the eye, but mainly for patients who are resistant for now to other treatment, for switch patients. So I agree with you that after we see these events, and with other drugs, we have much less such events, not zero, but much less such events, we are less enthusiastic to use the new drug on naive patients that may respond to everything. But for the patients that, like Professor Reak showed, patients that are not responding well enough, patients that need for years monthly injections and are sick and tired of these and are not coming and are losing vision because they're not compliant, I think these patients are a good option with, exactly like Matus explained, with examining them, with explaining to them, with monitoring them. I think there is still an option for the drug in this kind of patients. And when we will get more experience and more confidence, maybe also for other patients, but at least at the beginning, for me, it's suitable for these kind of patients.
Yeah. Thank you, Nat. We have one more question that it is relevant and perhaps very close to what we are discussing, coming from Dr. Karabelas. He's asking, Professor Reak, do you routinely perform slit lamp examination on the day of injection?
Yes, we do. And we did it also before brolucizumab came, probably as maybe only one center in Germany, but we really invested this time. We do constantly over years, visual acuity, OCT, and fundus investigation before we inject every single injections. Doesn't matter which drug is it. So for us with brolucizumab, we couldn't, or we do not need to change the rules because we already did it before. But this is the German recommendation for everybody who is not looking to the fundus or doing the OCT prior every single injections. Even nowadays with treat and extend, the most of the colleagues are doing it. So, but yes, at least at brolucizumab cases, look at the slit lamp and look also to the fundus.
Good. This is very important. Also, if we take it into consideration what you already have suggested, Matus, that if you detect this situation early enough, the possibility that you will avoid something really serious is very high. So if you are somehow very careful when you're examining your patient, the possibility to encounter a big problem is much, much smaller. So this way you can somehow make your strategy safer. And there is one more question from Ms. Triantafylopoulos, but I think this has been already
answered this
yes, by Anat. And one question from my side for both of you. So we have a new drug, a potent drug, and I'm wondering, so you have a patient like the one Matus showed, and he has received everything, all the drugs that we have, and at the end, there is still disease. You have fluid, you have edema, you have everything there. And you start the new drug and puff, everything disappears. So my question is, what is the reason? What's at the very end, after having a patient under treatment for 3-4 years, receiving injections, at the end of this, story, what's happening? You have huge amount of VEGF there, or there is something related to the drugs? What do you suggest? I mean, nobody knows, but what would be your idea? Why a potent drug? Because we're speaking about a drug that it is probably more potent than the others we have. But what's the reason? Can you comment?
Yeah, shall I start?
Yeah, go ahead.
Okay, thank you. So you're absolutely right. And this is also what we are asking. If we are talking or thinking about this tachyphylaxis as we saw it with aflibercept or ranibizumab, would it also come with brolucizumab? Nobody knows. I think our experience is not long enough to answer these questions. I don't think that these eyes have more VEGF or something like that. I don't think that the disease changed. This is maybe there is something that the receptors are not reacting so well after long treatment. And this is a completely new drug with, as Anand explained, is a completely new technology. This is something what we also need to say. This is the first clinical use of this kind of technology they developed, because it's technologically very difficult to produce drugs in these single chain antibodies. So they are very small, maybe, and they are reacting at different targets. So maybe therefore there are also bit better effects on these very tough cases, as I showed you. But I have no evidence-based explanation.
I think it's an excellent question. And as Matu said, no one knows the answer. One thing we know is that we give them many more molecules here, as I explained in the beginning, many more molecules. And probably this has something to do with it. You know, we have this situation of, I know that all the issues with switch between drugs, that some people say just regression to the mean, and actually it doesn't matter if we switch or not. But still, you have a patient that is on a certain excellent drug and doesn't respond. You switch him to another drug and he responds even before. And no one actually exactly knows one person will respond to one drug and not to the other. I'm talking about the registered drugs that are very similar in their potency. So I think it may be the amount of the molecules that causes increased effectiveness and also increased duration. But as both of you said, I don't know the exact answer to that. I think we still need to learn a lot about it.
Thank you. Thank you very much, both. I think we are just on time. It's 2 o'clock. Thank you very much. Thank for the participants that followed us and for the questions. And I think we can conclude now. Thank you. Thank you.
And next year we want to come to Athens or to wherever in Greece.
You must come to Athens, both of you.
Yeah.
Thank you. Hello. Bye.
Bye. Bye.